burns was discussed with you. Dr. Damodar has taken. So I'll be concluding with the second half of the burn topic. Okay, we'll just begin. Before we start with we'll talk about the management of the burn today. So just a quick revision of what you have learned in the last class. Do you remember? Any one of you? Do you remember what is the degree of the burn? Anyone? Okay, just look at the slide. According to the depth, we classify burn into first degree, second, third, and fourth degree burns. Okay, so the first degree burns, the epidermis is only involved. Okay, the second degree burn, you have epidermis and the superficial type of dermis. Okay, so that is called second degree superficial. In the second degree deep burn, you have the second epidermis and the entire dermis. So in the second degree superficial burn, only the burn depth is still the papillary layer of the dermis, and in the second degree deep burn, it's still the reticular dermis. Clear? In the third degree, the burn extends till the subcutaneous layer, but does not involve your muscle, tendon, fascia. Whereas in the fourth degree, it reaches till the muscle, tendon, fascia, even bone also. Okay. So with this basic knowledge, we will advance. We'll see the management. So you can see in the picture what I have just taught you. First degree till the epidermis, second degree till the dermis, third degree subcutaneous, and fourth degree is deeper. Right? So these things you have been taught before, I guess. Okay. So you remember this picture, Wallace Rule of Nines? Anyone? Anyone? Do you remember? No? Okay. For you, for second year MBBS, how do we calculate how much percentage of your body has been burned? It's by the most common formula that we use is called the Wallace Rule of Nines, in which we divide the segments of the body into multiples of 9. Okay, so you can see the head, the front, and the back. It contributes to 9% of the burn area. The thorax and the abdomen is 18% front and the back. Okay, in the upper limbs 9. Okay, each, and the lower limbs are 9 each, and the perineum is 1%. Okay, so all these together make up 100% of the surface area. So let's start how we'll evaluate the burn. So see, in surgery, in trauma, am I audible till the last bench? Can all of you hear me? Sure? Please nod your head if you can hear. Can you hear that guy last? Okay. So in surgery, in trauma, any trauma patient comes to you. So how will you manage in the emergency, in the casualty department? So we have something called ATLS criteria. Have you heard the term before? ATLS stands for Advanced Trauma. Okay. So ATLS stands for Advanced Trauma Life Support. Okay, that is a system or a procedure by which we manage surgery trauma patients. So in it we have two broad headings. One is called the primary survey, one is called the secondary survey. So any trauma patient comes to you, suppose fracture ho gaya, yeah, any fall from height, yeah, road traffic accident or drowning case, anything. So the patient comes to you, first we will do primary survey, in which these things we check first. It starts with ABCDE. In A, it stands for airway. You'll check the airway, which are the nostrils, the mouth, the pharynx, larynx, your trachea, bronchus, till the alveoli level. All these constitute the airway. Okay. So how do you assess the airway? You just simply ask the patient to speak. If the patient can speak out, that means the airway is patent. Okay. If not, you check the nostrils and the mouth for any bleeding, any mucus secretions. Okay, any foreign body lodged inside there. So if any of these things are there, you do suctioning, you take out the secretions, blood, everything. You try to make the airway patent, right? Then the next thing is called breathing. See, if the airway is patent but the patient is not breathing, then there won't be any gaseous exchange. The air inside the airway, it will be, stagnant. So if it's stagnant, then carbon dioxide will build up. So for gaseous exchange, you need to breathe in and out, in and out. Okay, so the fresh air comes in and the carbon dioxide goes out. So to assess the breathing, first of all, we will do inspection. We'll check the chest movement. You just remove the clothes of the patient and you check if the chest is moving up and down or not. Okay, that is inspection. And in the palpation not needed. You do auscultation. In auscultation, you check for the breath sounds. If air is going inside, you will hear that the sound of the air is going inside the lungs. So that is how you assess the breathing part. Okay. The next comes your C, circulation. Circulation mein you have to check how is the blood flow in the system of the body. So we do that by checking the blood pressure of the patient, and you check the pulse rate. From the pulse rate, you can check the volume. If it's good volume, that means patient has not undergone hypovolemia till now. Okay. If the pulse is feeble, that means the patient is losing blood, either from the external wound, or the patient is bleeding inside the body, like from liver, spleen, kidneys, whatever, bladder. Okay. So the pulse gives us a good idea about the volume of the blood. So the next thing is disability, in which we will check for the GCS. GCS means if the patient is oriented to time, place, person or not. Okay. What is the size of the pupil? Is it reacting to light or not? Okay. And if the patient can speak and move his limbs or not. So all these things constitutes the GCS. It is basically your central nervous system examination. Okay, GCS. Then last we have exposure. You remove properly the entire clothes. You check for any other injury in any part of the body. Okay, and hidden. So before you do exposure, you have to take the patient in a properly private area, and the room in which you examine, it shouldn't be cold, it should be warm enough. Okay, so that the patient doesn't have hypothermia. Okay. So the next part is the secondary survey, in which the mnemonic is ample. In ample may, so after you have done the primary survey and the patient is a bit stable, then we go on to the secondary survey, in which first is A for allergies. You will ask now you will be in secondary survey, you will be asking about the detailed history of the patient. We will ask about the allergy and the medications, what he or she has been taking in the past for any other medical comorbidities. Okay. Then P, the previous medical history. Okay, or if the patient is pregnant or not. Okay. Then the next is L, when was the last meal intake by the patient, maybe few hours back or 1 day back, sorry. Then E is the events that has led to the injury at present. Suppose a patient comes to you in casualty with a fracture of the right arm. So you'll ask how has the fracture happened? If it was because of a collision with another vehicle, or the patient has fallen down from 2 or 3 story building. So what are the events that has led to the morbidity at present? Clear? So Now we are talking about burns. So the very important thing is the fluid management. So what type of fluid, how much fluid you give to the burn patient, that is important. So so these are the very basic formulas which we use. For you, the most important that you have to remember is the Parkland formula. Okay, in which it's 4 into the body weight of the patient into the percentage of the burn that has happened in the skin surface. For example, if we take a 100 kg patient, so 4 into 100, and suppose the burn area is 10 percentage of the burn. Okay, so 4 into 100 into 10, it comes out to be 4000. So 4000 ml is the total fluid that you will be giving to the patient in a span of 24 hours. So out of this 24 hours, in the first 8 hours you will be giving 50% of the fluid. That means 2 liters or 2000 ml you will be giving in the first 8 hours, and in the next 16 hours you will be giving the rest of the fluid. Okay, that means the rest 2000 ml. So after you give the fluid, you have to check if the patient is recovering well or not. So the most important indicator to check if your fluid is working and the patient is becoming well or not is urine output. Okay, so once you are giving fluid, you will check the urine output of the patient. If the urine output, the volume is good, that means your resuscitation or the fluid you are giving is working. And apart from that, you will be checking the blood pressure of the patient, the pulse rate, the volume. All these things will improve once you start the fluid resuscitation. Clear, everyone? So another 2 formulas that we use is the modified Brooke formula, and another is Galveston formula. Galveston is used mainly for pediatric patients, child burn. Okay. Modified Brooke is just the half of what is in Parkland. Okay. So you see, in modified Brooke, in children less than 14 years, we give 3 ml per kg per total body surface area of burn, and in the electric one, we just double it. We make it 4. Okay. So just know the formulas in exam. No need to go into the very details. There are a lot of calculations. So what are the fluids that we use in burn? We just cannot simply use any kind of fluid. Since you are in second year, so when you come to the final year, we'll talk about the fluids in detail. That is a separate chapter. For as of now, you just know that in burn we use most commonly ringer lactate, RL we call in short form. Okay. So in children we use RL with dextrose. Dextrose is basically your sugar. Okay. The next we can use hypertonic saline. Okay. And next is albumin, human albumin. It is available in 20% also and 10% also. Okay. So one important thing here is when you infuse albumin to the patient, you give it after a few hours. After 12 hours, the burn has happened. Not just immediately. Suppose the burn has happened just now, you don't give albumin, because what happens whenever there is a burn, there will be an inflammatory reaction. So as you know from pathology, when there is inflammation, initially what happens, there will be vasoconstriction first of all to control the bleeding. Then slowly there will be vasodilatation to because of vasodilation there will be leakage of the fluid. Okay. Along with the fluid, the albumin will also leak out of the blood vessels. Okay. So when you give albumin in less than 12 hours of burn, this albumin will be going to waste. It will go into the interstitium. Okay. So it won't have any function. Okay. That's why we give it after 12 hours. The basic function of albumin is to absorb the water, to increase the blood volume. As you know from physiology, albumin is a large molecule. It attracts water, it improves the blood volume. But because of inflammation, it will be lost during the first 12 hours. So we'll give it after that. Okay. So when do we give fluid? In adults, if the burn surface area is more than 15%, that time we give. Or in children, if it's more than 10%, that time we start giving the fluids. Okay? Less than these values, it's not needed. You can just give the patient orally. That will suffice. Okay? So inhalational burn. Now this is very important because see, if any patient has burn in the respiratory tract, what happen will is like inflammation will follow. There will be edema, so the respiratory passages will get blocked. The air entry will decrease, and the patient will have shortness of breath. So in simple terms, the patient will have a choking kind of sensation and will die. So inhalation is very important. Okay. So the things that you have to know, like how will you know if the patient has suffered inhalational burn? First of all, from the history. There will be history that the patient has been in an enclosed room. Okay. Secondly, there will be singeing of nasal and nasal hairs. Okay. The hairs around the face and the nose, it will be burned. Okay. Thirdly, there will be blisters around the soft palate, the hard palate of the mouth, neck, all those areas will be there. Then there will be changes in the voice, hoarseness will be there. Okay, and the patient can have even shortness of breath also. And in these patients, when you take X-ray, there will be consolidation. That means some patchy infiltration in the lung parenchyma. Okay. So all these things together, the history, the examination and the X-ray, all these things, when you combine, it will give you an idea about the inhalational burn. Now, what are the dangers associated with the inhalational? If the patient has inhaled hot gases, you know where is the glottis? It's a part of the larynx. Okay. So when patient has inhaled hot gases, there will be supraglottic burns, okay, and laryngeal edema. In case of inhaled steam, there will be subglottis burn and the epithelium of the respiratory tract, it will be desquamation. The cells will die. Okay. So the cells lining the respiratory tract is pseudostratified ciliated columnar epithelium. If you can remember from your histology first year. Okay, the cells are lined by cilia, right, to propel the movement of the foreign body and the mucus. Okay, so all these cells will be lost because of the burn. Now, if the patient has inhaled smoke, the smoke will be containing a lot of chemicals. It will go into the parenchyma of the lung. It will damage, leading to pneumonitis and later on pneumonia. Okay, eventually causing respiratory failure. Then comes your carbon monoxide poisoning. Carbon monoxide binds 200 times with greater affinity to hemoglobin. So it will displace the oxygen and it will irreversibly bind with the hemoglobin, causing poisoning. Okay. So what is the treatment of carbon monoxide poisoning? We give vitamin B12. Okay. Now, if the patient is having chest burn around the chest, so initially, like after a few days, what will happen? The burn, any wound, when it's in the healing phase, when it starts to heal, it will start to contract. Okay? So when the chest, it starts to contract, the patient will have difficulty in respiration. Okay? So all these things are the dangers associated with inhalational or respiratory tract burn. This management is for the inhalational burn. Okay, that will apply to you. So first of all, I have told you ATLS evaluation. Okay, airway, breathing, circulation, disability, exposure, all those things will come under primary survey. Then we will do the secondary survey. Okay, so any inhalational burn patient has come, you will check all those things. Okay, primary done. Secondary survey you will do only when the patient is stable. Okay, you will take the detailed history in the secondary survey. So here, if the patient is serious, you will just do the primary survey and you will proceed with the stabilization of the patient. Okay. So after ATLS, you'll do elective intubation. You know what is intubation? Have you heard the term intubation? What is it? It's basically putting a pipe in a hollow organ. Okay? So in this case, intubation means we put a pipe through the mouth into the trachea, into the larynx, okay, in order to oxygenate the lungs. Because in inhalational burns, I said there will be inflammation in the larynx and all. So there will be edema and the respiratory tract, it will get occluded, it will become narrow. So the patient will go into respiratory distress. So to prevent that, when the patient comes to us in casualty, we will put a tube, okay, and we will start giving oxygen to the patient, okay, before the airway becomes narrower. So there is a window, there is a time period. It is between 4 to 24 hours, between 4 to 24 hours of burn, okay. We use 100% oxygen for 40 to 60 minutes in order to flush out all the toxic substances that the patient has inhaled. Okay, next thing is, so you have intubated the patient. Next, we will give bronchodilators, okay, to dilate the bronchus so that the airflow can increase. So what are the agents that we use? We use salbutamol, albuterol, okay, formoterol, all these things. The next is nebulized heparin and nebulized N-acetylcysteine. So these two agents, heparin and acetylcysteine, they will be acting as a mucolytic. Because of inflammation in the respiratory tract, there will be a lot of mucus that will be accumulating. So to break down this mucus, we use these two agents. Okay. Then next we have chest physiotherapy. Just the treatment is not enough. You have to do physiotherapy. Just like in injuries and fractures, you just do bandaging and dressing, that is not sufficient. You have to make the limb movement. Because if you don't move the limb or the area affected, there will be something known as disuse atrophy. Have you heard the term? Disuse atrophy. If you don't use a muscle, it will slowly start to become, it will shrink in size. There will be atrophy slowly. Okay. So to prevent that, in this case also we will do chest physiotherapy. Otherwise, you have your serratus anterior posterior muscles, then all those muscles which help in respiration, it will go into atrophy and the patient will have difficulty in breathing in later point of life. Okay. So dressing is very important in burns. So see, first of all, for dressing you need some agents. Okay, it can be either any semi-solid agent or it can be a liquid agent. When it is a semi-solid agent, for example, any ointment or any cream or paste, that we call as salve, SALVE. Okay. Now, what are the agents we use? One is sulfadiazine. You know what is Escar or Escar? What is that? Just after a burn injury, the skin becomes black colored like a charcoal hard. Okay, the byproduct of burn, that is called Escar. Okay, so silver sulfadiazine, it cannot penetrate the Escar. Okay, that is the disadvantage, but it has got broad spectrum antimicrobial effect. That means it can kill both gram positive and gram negative bacteria. Okay, then it can also even cause black color tattooing of the skin. Okay, so it's cosmetically not good, okay, for the patient, for burns on the face and all. Next is mefenide acetate, 11% we use. That is also a broad spectrum agent. Okay, it can penetrate Escar. Okay, but the side effect is that it causes metabolic acidosis. Okay. Other agents that we use is bacitracin, neomycin, polymyxin. There is too much stuff for you in second year. Okay, but still just know the names as of now. Nystatin is used for fungal growth. Okay. Then next thing is antimicrobial soaks. These are liquid solutions which we pour over the burn area. Okay. So what are the agents we use? Silver nitrate, mefenite acetate, sodium hypochlorite, which we also call as Dakin's solution. Okay. Then acetic acid is there, which we call as Domboros solution. Just the names. Okay. So see, after a burn injury is there, you are doing dressing. Sometimes the burn is so big that you cannot simply close the wound and suture it. So in those cases, you have to put another layer of skin. Okay. So that skin can be either biological or it can be artificially made in the factories. So if it's biological, you can either take it from the body of the patient itself. Okay. Suppose if I have a burn here and if I have to cover it with skin, I can take it from my own thigh, okay, or the buttocks or the back. So I take it from there. I can use to cover my wound here. Okay. Or you can take that skin from a cadaver also. Okay. Or from a pig. So if it's between a different species, it's called Xenograft. If it's from the same species, it's called Homograft. Okay. And if the patient is what do you say? If the patient is supplying himself or herself, it's called Autograft. Okay. So it's self-explanatory. So these synthetic coverings, these are the brand names. These are basically your artificial skin. Okay. Opsite, BioGrain, Transite, these are the brand names that are being used. Of course, these are extremely costly, so not used everywhere. So burn surgery, okay? It is done for mainly your second degree burn and above. For first degree burn, which is limited to the epidermis, no surgery is required. Clear? For second degree and above, we do. So before you do any surgery, you have to make sure that there is no bleeding. So to prevent that, there is no bleeding, there is no pain, because you'll be cutting the skin. So for that, we use lignocaine, okay, to decrease the pain, and we use adrenaline to decrease the bleeding. Okay? So we use this combination. So the ratio is 1 is to 10 lakhs or 1 is to 5 lakhs. That is the ratio that is being used. Clear? So you can even use a tourniquet to, suppose you are doing a surgery here, you can tie a tourniquet above to decrease the bleeding also. Okay. The next is skin grafts. After you have, so whatever surgery you are doing, you know what is a graft? I think you have heard in biology before. Okay. So graft, you can either use those biological agents or the synthetic agents to cover that burn area. Okay. So what are the various surgeries that we do? One is escarotomy, one is tangential excision, one is full thickness excision. Okay. So after the surgery, we do something called as splinting. Splinting means to immobilize that operated area, okay, to prevent dislodgement of the sutures and to prevent pain. So, but if we keep that part immobilized for a long time, there will be again atrophy, disease atrophy. So, after a few days, you have to start physiotherapy, okay. So, splinting in the initial periods after the surgery or burn, dressing, followed by physiotherapy, active movement of the fingers or the feet or the leg, whatever. Okay. So what is escarotomy? So in this case, we don't, suppose Escar is a black color hard tissue that is formed after a burn. So here, this escarotomy is an emergency procedure. Suppose a patient has Escar here on the hand, okay, circumferential Escar is there. So this will contract this area here. Because of this contraction, there will be syndrome that is happening. That is called compartment syndrome. See, if you put a tourniquet, if you keep it applied for a long time, you will see it gets swelled up because of edema and all. So same thing here, it's happening. So because of this edema, the blood flow will decrease and the patient will have increased pain, and slowly this part of the body can go into gangrene. So to prevent that, we do escarotomy. We don't remove the Escar as a whole. We just make an incision so as to decrease the tourniquet effect. Okay. If it's in the limbs or in the chest, if it's in the chest, the patient will have problem with respiration. So you just make an incision, you decrease the tourniquet effect, okay, and later on you can do another surgery. So escarotomy is an emergency decompression, okay, to prevent compartment syndrome or respiratory distress. The next surgery that we can do is tangential excision, in which we shave and remove the burnt area layer by layer. Okay, we just don't remove it in one go, we remove it in thin slices. Okay, so when do you stop removing the layers of the burnt area? Till you see bleeding. Once you see bleeding, that means that area is viable, or the blood vessels or capillaries are intact in that area. So you stop till after you have seen that punctate bleeding, we call, okay, pinpoint bleeding. Right. So tangential excision is done mainly for second degree burns. Okay. The blood loss in this case it will be high because you have to check for the bleeding here. So after you have done this excision, then later on you can put a skin graft over it, okay, to cover the wound. In full thickness excision, we remove the burnt skin, subcutaneous, the muscle, okay, all these layers we remove, and after that we put a flap, not a graft. Graft is your only skin. A flap is when you include skin or subcutaneous or muscle, these 3-4 combinations together, that is called a flap. So flap is thicker than a graft, okay. So see, when you are doing a full thickness excision, there will be a hollow, there will be a lot of big space. So that cannot be just simply covered by your skin only. You need something more that has more volume. So that time we use a flap. Okay, we take some fat or muscle or bone from another part of the body and you just place it on that hollow area and cover it up. Okay, then you do dressing, you'll do splinting for a few days, then you start physiotherapy. In this manner, we proceed with the dressing and the surgery. So this is excisional surgery. That means excision means you cut and you remove. Okay. If you see escarotomy, we don't remove anything from here. We just make an incision. We decompress. Okay. So that is called an incisional surgery. We just make an incision. But tangential excision and full thickness excision, we cut and remove the burnt area. Okay. So these two are excisional procedures. So these are the lines along which we do escarotomy. So if you look in the upper limbs and the lower limbs, these are along the long axis of the limbs. Okay. And in the hand, you can see these are along the radial and the ulnar border of your hand, okay, longitudinal. So this is called tangential excision. You remove slice by slice till you can see here punctate bleeding, it's red, so they will stop it here after they have seen the bleeding part. Okay. So now nutrition, just an overview, it's important. We start nutrition in 15% burn area in adults and in more than 10% area in children. Okay, so in burns in which there is more than 20% burn area, you do something called as nasogastric or nasojejunal tube. Okay, in which what we do, we put a pipe through the nose into the esophagus, then we reach till the stomach, Okay, when we reach till the stomach, that is called nasogastric tube. When you reach till the jejunum, that is called nasojejunal tube. So through these tubes we put new solutions, or we provide nutrition to the patient. Okay, because after the burn, as sir has taught you in the last class, pathophysiology, the GI mucosa, it starts to go into atrophy. Okay, so to prevent that mucosal atrophy of the GIT, we have to start the nutrition as fast as possible. Clear? So for the nutrition, some formulas are there. Just know the names: Curary, Davis, Sutherland. Now we'll talk about alkali burns. See, if you get acid, if acid falls or any alkali falls on your skin, you don't try to neutralize it with the opposite agent. If you get an acidic burn, you don't put alkali, because as you know from chemistry, acid and alkali, it's an exothermic reaction. It will release heat. So there will be more burn. So what you do, you just wash it with tap water for 10 to 20 minutes. Okay. So alkali burns, how does it, like, what is the mechanism? It will cause liquefactive necrosis of the skin. So once there is liquefactive necrosis, the alkali, it can penetrate more deeper inside and it will cause more burn. Okay. Whereas in acid injury, it will cause coagulative necrosis. So the coagulum, it's hard. It cannot be penetrated by the acid. So it won't cause any further deeper burns. Okay. So alkali burn is more dangerous in simple terms. Okay. So treatment is you wash it with a lot of water till the pH of the skin, it becomes 7 to 7.5. Okay. After that, whatever dead tissues are there, you can do tangential excision. Okay. Then later on, skin grafting you can do. So acid burns, I have told you. It's not needed too much. So last topic, we'll finish up electric burns. There are, in electric you have two types. One is low voltage, one is high voltage burns. So the problem with the low voltage burn is that it disturbs your rhythm of the heart. Okay, so it will cause disruption in your cardiac pacing, but the degree of the burn will be smaller with the low voltage burns. The burn injuries that you suffer at home, household, that is low voltage burns. Okay, in high tension wires in roads and all, the high voltage burn happens when you touch the high tension wires and all. So this high voltage burns, it causes deeper tissue injuries. Okay, it causes direct myocardial damage, unlike in case of low voltage burns, where the conduction of the heart is disrupted mainly. Okay, why are you smiling, bro? Don't smile. I said don't get distracted during the class. I know it's a bit boring, but don't do that. Okay? If you want to sleep, you can sleep, no problem. But don't disturb me. Clear? So what happens with electrical burn is that when the electricity passes through your cells, it will damage the cells. Now the cells contain a lot of potassium. So the potassium will increase in the blood. It will cause hyperkalemia. So this hyperkalemia will lead to your fibrillation, ventricular fibrillation, in which the heart cannot pump effectively blood to your whole body. So that will lead to your failure of circulation and eventual death of the patient. Okay. So this electricity can also destroy your muscles. Then myoglobin will be released. This myoglobin can cause renal failure. It will go and block your renal tubules, causing renal failure. Okay. So there will be hyperkalemia causing ventricular fibrillation. So there will be myoglobinuria causing renal failure. Okay. So management is same. ATLS will do ECG to check for the electrical rhythm. Then we will do serum electrolytes to check for the potassium. What is the level? Okay. Then mannitol will give. Mannitol is basically your diuretic. It will flush out the excess myoglobin from your body. Okay, so that it prevents your kidney injury. Since you are giving mannitol, it will cause diuresis. There will be dehydration in the body. So you have to give the patient fluids also. Okay. Then you will check the urine output. As I said earlier, if you are giving fluid, in order to know if the patient is getting well or not, you have to check the urine output of the patient. Okay. So in electrical burn, the urine output target should be 1 to 2 milligram per kg per body weight. Okay. Then lastly, you have to do surgeries like fasciotomy or escarotomy, in which fasciotomy is done mainly for compartment syndrome. Okay. And escarotomy, like you do an incisional surgery to prevent any breathing difficulty or to decompress any compartment. Okay. So long-term complications is contracture after the burn. Contracture is basically because of your fibrous tissue. Okay, mainly happens at the neck area and the upper part of the chest. So we do something called a Z-plastic, not needed for now. So you can see a burn scar here. So what they have done, they have put a zigzag incision in this plane at the burn area. So after that, they will stretch the zigzag area and they will suture it up. So leading to the free movement of the limb. Okay. So this is basically your Z-plastic, what we call it. So after burn area, we can have something, complication of burn. Long-term complication is Marjolin ulcer. It's basically your well-differentiated squamous cell carcinoma. So if this happens, what we do is we excise and we remove that ulcer. But we take some healthy tissue margin also along with the ulcer. For example, see, this is a Marjolin ulcer. So what we do here is, this part is the ulcer. We will take 2 centimeter margin from the burn margin and we will make an incision like this and we will remove this whole diseased chunk along with some thin rim of normal tissue. So this is called wide local excision. You can see 2 centimeter margin we have taken from the pathology area. Okay. Done.